Good morning, everyone. We'll wait just a few more minutes and let a few more people in, and then we'll get started. In the meantime, if you wouldn't mind typing your name, your role, and where you're from in the chat.
Janine, I just want to announce that I am hearing impaired. As a coworker, you know that, but for the presenters and speakers, I don't generally have problems on Zoom, but it's an invisible disability bringing forward.
Great. Thank you, Matthew.
Thank you. Okay.
Well, Louisa, if you want to get started.
All righty. I was getting kind of mesmerized by watching the chat and seeing where everyone is across our very toasty state. I myself just got back from a trip to Ventura, which was really refreshing because it was cool down there in places. Anyway, I am Louisa Guardioni. I am the newest member of our older adult behavioral health team in Josephine County. I have the joy of introducing Angela Franklin, my counterpart in Josephine County, in just a couple of minutes. But first, we have to do a couple little businessy things, as I'm sure you are all familiar with. So please, as we get going, don't put your name and your role and where you're from in the chat, and we'll get started. Okay. So we are all here together to participate in our Navigating Advanced Care Planning, which Angela Franklin will be teaching us today. All right. Please mute your mic. We'd like you to utilize the chat for questions and comments, and we'll get to them either at the end or as we go along. You will receive a follow-up email with the slides and a link to the recording. Also, any training materials and surveys for the CEUs and certificates. Learn how to talk today. All right. We are currently recording, and the recording will be posted to our OABHI YouTube channel. We do need to have your faces present so that we can count your live attendance to get the CEUs. Very important for all of us, keep a track of all of that. To claim the CEUs for today's training, don't forget to complete the surveys that you'll get at the end. And there's also, there's an NASW CEU survey, and there's also a certificate of attendance. The PESU survey for today's training is important for us so we can know more about what you learned, catch future topics of interest, and let us know how we're doing with suggestions, comments. There's an evaluation link to do that. All right. All right. Just a little bit more about the Behavioral Health Initiative, which is what we are all a part of. Angela and I and our Jackson County counterpart who is present today, Janine. So the Behavioral Health Initiative for older adults and people with physical disabilities was launched back in 2015 to meet the needs of older adults and people with disabilities by improving timely access to care from qualified providers who work together to provide coordinated, quality, and culturally responsive behavioral health and wellness services. All of our specialists engage in collaboration and coordination in the systems of care, help build knowledge capacity through free workforce development trainings and community education, as well as provide complex care consultation. So a lot of things everyone does across our state to provide those services. There's about 24, 25 of us, I think, at this time throughout the state, and some folks cover multiple counties, which I think is way amazing. So, all right. Now I'll just tell you a little bit about Angela, who's going to be teaching us today. If I find where I put her blurb. Angela is an advocate at the intersection of life's most profound moments. As an older adult behavioral health specialist, suicide prevention coordinator, and death midwife based in Southern Oregon, she brings a wealth of knowledge and compassion to her work. Angela is certified as a respecting choices advocate, care planning first steps, and advanced steps instructors, which she uses to empower individuals and families as they navigate complex end-of-life decisions with clarity and dignity. I can't wait to learn more about those programs. Okay. With a passion for education and empowerment, Angela delivers let me try breathing. With a passion for education and empowerment, Angela delivers dynamic trainings on topics ranging from older adult behavioral health and wellness to advanced care planning and suicide prevention. Her diverse background as a caregiver, hospice volunteer, end-of-life doula, and community educator uniquely positions her to provide comprehensive support to those facing life's transitions. I think we are all going through that at one point or another. Angela is committed to fostering connections and compassion within communities. Her dedication to creating spaces of healing and growth reflects her unwavering commitment to the well-being of those she serves. She is the co-founder of Journey Home Support Services. Journey Home is a community-driven organization based on practical death care, education, outreach, and community grieving support. I am so glad to have this opportunity to share that with all of you and to sit in on this training that she's going to present. Go for it, Angela.
Awesome. So I think someone commented that I was in presenter view rather than regular view. So is everyone seeing the way I want you to actually see it? Okay, good. So one of the things that I did not have the slide up, so Louisa, you didn't know, but we do have some upcoming trainings in this Gero competency series. So, and I don't know if I was busy looking at other things. If you mentioned these, Louisa, did you?
I did not. I do have
Okay.
a slide, but I thought Janine was going to throw
Perfect.
that into her dialogue at the end to get
so
people interested
just
now and then tell them more later.
for those that maybe have to pop off, I'll let you know that we do have 2 upcoming trainings. Next month, we have Mental Health Advanced Directives with Dr. Avila. And then in October, we have Dr. Nash doing Managing Challenge Behaviors in Residential Care Settings. So both of these are also CEU, and our Mental Health Advanced Directive, we were able to get ethics CEUs. So for those of you that need to fill that ethics, so this is available to ethics CEUs. Okay, so yay, we're here. So what you're going to learn today is this is a little deeper dive into advanced care planning and looking at how to make it more accessible, for a range of people. So we will spend a little bit of time talking about just the foundation of what advanced care planning is. We'll look at the different documents that we utilize and talk about the process of advanced care planning. We're going to look at the current culture around advanced care planning, some of the key challenges and disparities faced in the implementation of it and the delivery. We're going to look at a range of culturally specific considerations, looking at different marginalized populations and looking at how to create health equity and inclusion within our advanced care planning process. And then I have a bunch of resources that I will be sharing with you all. So the very first thing that I want to talk about is, what is advanced care planning? A lot of times people think that it is a one-time conversation or filling out your advance directive. And that is not the totality of what advanced care planning can be. So it is a process. It's not a single event. And I have broken it down into 3 different things. So the first is that there is a lot of exploration that needs to happen. And sometimes we need to help facilitate that exploration with people to find out what matters most to them. What information do they need to make informed decisions? And what are their preferences? So if there is an event that happens, what do they want their care team to look like? And especially with some of the people who have disparities within our systems, it's important to have advocacy for these people. Conversations are one of the hugest parts of advanced care planning. So conversations with our appointed decision makers, if we have folks, conversations with our family, and conversations with our healthcare providers. So it again is not just a one-time conversation, because you have to build upon conversations so that everyone has an understanding. And then, of course, there are the forms and the documents that are really helpful and can give a person autonomy to when they don't necessarily have access to advocacy. And it is a good way for people to understand a little bit more about folks, and then give the legal right to make decisions to the people that you actually want making your decisions for you. So advanced care planning is important for all adults 18 and up. We are older adult behavioral specialists, but we also support people with physical disabilities 18 and up who have behavioral health needs. So this is for people who work with all ages 18 and up. So just keep that in mind, because it is a process that at any stage or age in your health, it is good to have a good understanding of what someone's values, goals, and preferences are, especially because a lot of the work that all of us do, I'm going to just assume most of us, are working with people who may not have the same advantages of others. And so we need to make sure that a younger person who may be unhoused, a person living with active drug use, or a serious mental illness, all of these people, no matter what their age, we are able to provide better support and advocacy for them. And a lot of the things around this deal with behavioral health as well. So when we talk about anxiety, we talk about not feeling supported. It just adds to our emotional and mental unhealth. So we want to understand an individual's rights to also accept or refuse medical or surgical treatment. And the advance directive is one of the ways that we can kind of frame that conversation. So it's important because it helps avoid costly unwanted interventions is one view. It also improves patient and family satisfaction around healthcare. It supports the goal concordant care at end of life. And it is shown to reduce moral distress among decision makers and healthcare providers. So if we're able to have this process, it can not just benefit the person, but all of the care team and people supporting them. And it can prevent hospital readmissions, ICU stays that don't reflect what a person wants. And so we will talk about what default, medical interventions are when you do not have any of these things in place. And then we also want to know that advanced care planning will look different as an illness progresses or changes. So we want to think about advanced care planning for future care. And so if you notice, it's advanced care planning, not advanced care planning. So there's no D at the end. That's because we want this to be ahead of time. So it's not something we necessarily want to be doing in the moment of having an acute medical crisis. We want to try to do this for future care. We also have advanced care planning for the urgent care for adults with serious illness who have potential for complications, and then also the end of life care. So advanced care planning for someone who is older and frail, and those who are, expected to possibly die within the next year. So advanced care planning, our conversations are going to look a little different depending on, where someone is at in these 3 different levels that we have. So when we're looking at our planning forms, this is where we use lots of different words about the same document, or we confuse documents because we will call them, all the same thing. So a lot of people talk about POA, power of attorney. Power of attorney is different than an advance directive. So a power of attorney, you can have one for healthcare or you can have one for finances. And you can actually, some lawyers will create a combined healthcare and finance power of attorney. I don't see it often, but sometimes people do that. So we will go over what the advanced care planning forms are that are most common and that can be utilized in Oregon. So we have our advanced directive, which helps us choose what kind of medical treatments someone does or does not want if they are terminally ill, advanced progressive illness, or permanently unconscious. So there's 3 scenarios that are given on our advanced directive. And you can choose what level of care you would want. So that looks like, do I want everything possible? Breathing machines, CPR. Our second level is more of, I don't want any breathing machines, but I want to try other treatments. And then the third level is comfort care. So that is going to allow for a natural death to happen. They're not going to do anything that includes breathing machines, medications and different interventions, except for comfort care. So pain will always be, worked to manage the pain. You will still get all of the other supports, but just not the medical interventions working to extend someone's life. So our Oregon Advanced Directive is really has some additional things. So every 5 years we get a new advanced directive, and we have a advisory council through the state that reviews and decides to add things and do revisions. And so the most recent advanced directive, they included a bunch of open-ended questions at the end of it where you can write a little bit of a narrative to express your general values, your hopes, what your concerns are. And it also has a section where you can say, ask, are there any other documents that you want included in your advance directive? And that is where we can add things like our dementia addendum, and maybe a values worksheet. So this is a place that you can add extra stuff, but it has to be documented in that section, and you include any of the additional paperwork with your advance directive when you submit it. The advance directive also allows you to choose a substitute decision maker when you can't communicate yourself, and not being able to communicate is due to an incapacity of some sort. So either you don't have decision-making capacity due to an illness. You are not able to communicate because you can't verbalize or write anything. So you might be have some level of incapacity. You can also choose 2 substitutes in Oregon for backup. So let's see. So the next one is the PULSE. We'll go over that a little bit more, but that's where you choose whether you want to have CPR attempted to resuscitate you if you're breathing or your heart stops, and what level of medical intervention you would like to receive. So we have full, selective, or comfort focused. Those are just kind of similar to our advanced directive levels of medical interventions. The dementia addendum is something that we do not have an Oregon dementia addendum, but you can add it to our advanced directive, and it helps you make choices about care based on the stage you are in within dementia. So dementia is progressive, and I'll talk a little bit about that more later. And then we also have what we call our mental health advance directive or psychiatric advance directive. It's referred to it as both ways. And the name of the document in Oregon is the Declaration of Mental Health Treatment. So this is where you can make decisions on future mental health treatments and preferences during a mental health crisis. And you do not have decision-making capacity at that time. So this is a really great form for people living with serious mental illness or have episodic illness, and that they ahead of time can talk about what works, what doesn't work for them, and to bring in caretakers and families. This is a very new it's not a new document, but there hasn't been a lot of training or education around it in Oregon. And so we're working to get more education around this, and that's why we're doing next month's training on it, is kind of our intro to some of the more intensive trainings that we're going to be working to develop around this mental health form. So I see, Matthew, you have your hand up. Do you have a question?
I do. So on the advanced directive, so I'm the AFH coordinator, and when you said that the state of Oregon updates these every 5 years, I work with the OARs in compliance. So if I sign something today and in 5 years it's been updated, is my original document, does it hold the same value as it did 5 years ago, or is it obsolete by the administrative rules? So I can help clarify that.
Yeah, it is not obsolete. So advanced directives will stay in place, and they will, be held. Your medical professionals will follow it kind of in perpetuity. So
no, I knew that. I figured maybe the medical professionals, but the way the rules for foster care and the Oregon Health Authority and how, if something's been updated with a rule, the new rule supersedes. So being in compliance, trying to help these homes be in compliance.
The what did I say? So the most basic elements of the advanced directive are all the same. It's just when they add those extra sections and if there is something that they change, that they will make it known that everyone needs to, so they'll make it known whether or
And then I
not.
put a situation in the chat, and then you might answer it a little bit later, but it deals
Okay.
with somebody who has a current guardian who had a previous advance directive. And if you can kind of answer that, because we've dealt with that situation.
Yeah, that's an interesting one. I don't know, but I can find out and answer that for you with the advance directive. I would assume that the advance directive, that the guardian would have to follow it because it was created before that she was deemed not having decision-making capacity.
That was our thought, and
Yeah.
that
So
the, but yeah,
that is my initial, but what we can do, I can ask and see if that actually is the case, and I'll let you know.
thank you.
Yeah. Okay. So the other thing before we move on is to let people know that the advance directive, if you appoint a person to be your decision maker in your advance directive, it will override whoever you assign as your healthcare power of attorney. So sometimes people will have both of these. Sometimes someone will just get a blanket healthcare power of attorney. And then if you do an advance directive and it's a different person, your advance directive person will be the one that the doctors will actually follow. So just know that. Okay. So I go into a little bit of just the difference between the advance directive and the POST, just so that people really understand, because I feel like people misspeak on this often. So an advance directive, which we refer to as a medical power of attorney sometimes, it gets referred to as a living will. It is it can be both of those because medical power of attorney, assigns a person. So our advance directive lets you assign a person, and the living will lets you state all of your preferences. So it is, can be considered both of these, but it's good to start talking about it as an advance directive so that we don't confuse people by talking about it as a living will or a POA. Because the advance directive has elements of those things, but that's not what it actually is. So please just refer to it as an advance directive so that we don't confuse people anymore. The POST, and you can see a picture here, it used to be all pink, but it was really hard to read and make copies of when it was all pink. So recently they made it just the outside is pink. So if you see someone that has an older POST, it might be all pink. So that POST stands for Portable Orders for Life-Sustaining Treatment or Physician's Orders for Life-Sustaining Treatment. People will kind of switch in and out those things. So the POST is an actual medical order. It turns a person's medical treatment preferences from like your advance directive, say, into a medical order. And it needs to be signed by an actual physician. And so I have this table here to kind of show you the difference between the two. So advance directive is a legal document. A POST is a medical order. An advance directive, anyone 18 and older can do one. A POST will only be done for someone who has a serious illness or advanced frailty. So a medical doctor will not sign off on a POST unless you are seriously ill or have an advanced frailty. The advance directive only needs to be witnessed by 2 people, and or it can be notarized. And then a POST has to be signed by a medical provider, and it can be signed by a MD, a nurse practitioner, a physician's assistant, or a naturopathic doctor. There are 5 credentials that can sign off on a POST. An advance directive is something that is going to be mostly utilized by decision makers to like have guidance on what someone wants, to help them advocate, and for hospitals, you know, and medical facilities to follow the different preferences. A POST is something that is used by hospitals, you know, when someone they need to know if they can do CPR or not, or what level of interventions they would want. It is also the only thing that will stop a paramedic from attempting CPR on someone outside of a hospital. So when people talk about a DNR, which stands for do not resuscitate, people will say, oh, I have a DNR. And so usually people are referring to that as a POST. So if someone says I have a DNR, then you can ask them, oh, do you mean a POST? Is it the pink paper? You know, and they're like, oh yeah, that's what I mean. Because there is actually a DNR. So a DNR is something that is hospital specific, that anyone 18 and over, when they get admitted to a hospital, they can sign a DNR that says do not resuscitate. And it only stays in place while they're engaged in that hospital episode. So if you get discharged, then it goes away. And then if you go back to the hospital, you have to re-sign a DNR. If you sign a DNR at a hospital, and then they have to transfer you to another hospital to see a specialist, or you know, to go up to OHSU for a special treatment, that DNR does not stay in place. It is hospital and episode specific. So this is why the PULSE was created. That's why it's called the Portable Orders for Life-Sustaining Treatment, because they wanted a way to have a DNR follow a person through any facility throughout Oregon, so that we didn't have to do this, you know, every single time. It's also why it is only for people with serious illness or advanced frailty. They didn't want to have it open for just anyone to be able to do. So does anyone have questions about either of these forms? Because it's just really good to get them kind of really solid, to know them solidly, so that we can talk about them in a correct way. Okay, so Bethany, you say, I always understood the advance directive was not considered a legally binding document, so a sort of choose wisely when you make a healthcare rep choice. That sounds like an awful situation. So it is a legally binding document, but there is room for like appeals. So doctors that might, some extreme situation, might disagree with it. There's ethics boards in hospitals, so they would have to go to the ethics board and they would have to review it, and it takes a lot to overturn someone's advance directive. And the POST, I said the advance directive is like, you sign it, it's good for the rest of your life, even though it's good to revisit it. But a POST, they really want you to do a POST every 10 years if you get one. So they will really question a POST that's older than 10 years. So you really do need to update POST at least every 10 years. Okay, let's see. Okay, I think. So Shoshana, yeah, so our new Pulse has we got a new Pulse 2 years ago, and it's different from the previous Pulse. There is a little bit of clarity that needed to happen. So a Pulse, the very first question they ask is attempt to resuscitate or do not attempt to resuscitate. And then the next section says full treatment, selective treatment, or comfort care. So the older one, if you put full, if you put, I do want CPR attempted on me, you were able to check off full and selective treatment, which is actually not possible. So the new one states, if you select attempt CPR, attempt to be resuscitated, your only choice is full treatment. So I have worked with individuals where I see an older post, more than 2 years old, and it says attempt resuscitation and then selective treatment. If you attempt resuscitation, you are going to be put on a ventilator. And so the likelihood that you are not going to be put on a ventilator is very little. And so that's why doctors it was confusing because it didn't tell us that we had to choose full treatment. So the new one, that is different. So if someone wants to be resuscitated, they have to choose full treatment. And then also if there's a section that says, who helped you prepare this? And so a place is where you can put the name of the person that helped you prepare and go over it, which is what I think Shoshana is talking about. So you can help a person go over the post, but the doctor is the one that has to sign it and submit it to the state registry. But most doctors are the ones that actually have the forms. You can get sample post forms to like work with a person, but more than likely the actual one that's going to get signed and submitted is going to come from the doctor. But you can use it as like a worksheet, the sample ones that you can print off of the Pulse website. And if I don't know if it's auto expunged, but I know that they do, they question it after 10 years. But I don't know if they have the technology to just like get rid of it after 10 years. Okay, these are all really good questions. Okay, so we're going to move along. So this all started, I just want to give a little history about advanced directives. So in 1991 is when we had the creation of the Patient Self-Determination Act. So this required healthcare organizations to ask adult patients if they had an advanced directive and to inform them on their rights to create one. It also asked that staff and community education be offered about advanced directives. So this is well-intentioned because it is a direct result of studies showing that certain people, there's some cases where people were kept on life support even when their families did not want them, to be kept on life support. And there were studies that showed that certain people that were seen as having less social capital or social worth were not receiving the medical interventions the same as people that were seen as having more social worth. So there are a number of studies in hospitals looking at the disparities between who actually got life-sustaining treatments attempted on them, how long were they attempted. The outcome is typically all the same, but it's still, we don't want to have certain people seen as not worth the effort, of having these measures taken. So even though it was well-intentioned, it did result in this disproportionate focus on legal documentation and making sure that patients knew their right to refuse treatments. So that has been the major focus. And over the last, 5 to 10 years, there's been this resurgence of having serious illness conversations, of having advanced care planning conversations to make it more than just a legal documentation. Because we know that there's so much that can happen that's beneficial within just the conversations about values, preferences, and goals of care. So we are getting better and making it more patient, person-centered. Okay, sorry about my text here at the top. So the current culture of advanced care planning, and this kind of will let you understand why maybe sometimes it doesn't happen like we wish it would, or we think it is. So it is a fee for service. So medical providers that conduct advanced care planning discussions, they are reimbursed, but it is time-based billing. It is provider driven. So a lot of times that means that it's not necessarily going to have a very long, because they can only do a certain amount of time within advanced care planning to bill for it. And it also is not necessarily a comfortable thing, or people getting trained in how to do these. So because it's fee for service, it kind of limits medical providers' ability to do these discussions. And then also there is a shift a bit for value-based. So this is where medical care people are reimbursed based on outcomes. So they're financially incentivized to improve outcomes of medical care. And so we know that advanced care planning can improve outcomes. And so they have this incentive to actually make it more of a team-based effort that's ongoing, and it allows for more culturally appropriate and accessible advanced care planning. So these are the two types, but the majority of our advanced care planning within the medical system is mostly the fee-for-service, based. And then we tie it to estate planning. So when we talk to someone like, how do you have your advance directive? And they're like, I actually don't. Yeah, I think that's what I did with my lawyer when we had our trust done. And then you ask, what was in it? And they can't recall most of the time, because it was more of like a checklist thing. I would hope that lawyers would take the time to have the conversations and really explore, but a lot of them don't. So this means that it's less of an ongoing process, less conversations are happening with decision makers, and now we have social economic disparities because not everyone can afford to go to a lawyer to do any of their estate planning or to do their advance directive. So it's really important that we don't continue, to just point towards your doctor or your lawyer as the way that we get these advanced care planning documents, initiated and completed. Okay. So let's see. I actually wanted to do a poll at the beginning and I totally forgot, because I'm very curious. I'm going to launch this. So I want to know how many of you here have a completed advance directive. So I have it here. We have yes, no, and then a lot of people are yes, I have it completed, but I have not turned it in to anyone. So this is very illuminating. We have just a few more people if you want to participate. Okay, I'm going to end the poll and I'm going to share the results. So we have 75% of you all do not have a completed advance directive. We had 5% said yes, and 20% said yes, but not submitted. So in reality, one person here has their advance directive created. 4 people have it created, but not submitted. And then we have 15 out of the 20 people who answered the poll do not have their advance directive. So this is something to think about. If you were in an accident, if you had a diagnosis, are the people in your life, have you had any conversations? Have you, talked about what you would want if you weren't able to communicate, even if it was for a temporary amount of time? Do you have these things? So I suggest if you are interested in being able to provide this to someone else, you have to complete this yourself. You have to know what it's like to personally read these questions and think about how it pertains to you. That is really the best way to understand possibly what the person is going to kind of be going through and possibly feel. So yeah, so please consider getting your advance directive taken care of. Okay, so
I have a question
yeah.
about DNR. If a patient chooses DNR, but want to choose like a limited treatment or a full treatment, can they do it? Like,
So a DNR would be, are you talking about a pulsed or the DNR that's hospital specific?
pulsed.
Yeah. So in the pulsed, if they choose to not be resuscitated, they can choose selective treatment or comfort treatment. So if they're not going to be resuscitated, then they can choose selective treatment, which means, we're going to do maybe the BiPAP breathing apparatus instead of the ventilator. Selective treatment would be I'm okay to receive antibiotics, to deal with an infection. I'm okay to, have a trial for this amount of time. So yeah.
Okay.
Yeah.
And they can choose both, like comfort treatment and limited.
No, they can just one choice. So you choose either selective treatment and you give the parameters of try it for this long. And then if it doesn't work, then I want to go to comfort, care. Yeah.
Okay.
Yeah.
Thank you.
Okay. I'm going to stop sharing stop sharing. Okay. Okay, so I'm going to talk about some barriers to advanced care planning. So healthcare professionals, these are the things that they have said are barriers for them to actually facilitate and do advanced care planning. So the biggest one is discomfort around having these conversations and lack of training in initiating end-of-life conversations. Limited time to engage in meaningful advanced care planning discussions, inconsistent or inadequate reimbursement structures for their time with patients. And then also a really big one is assumptions that advanced care planning isn't feasible for certain populations due to, social determinants of health, limited support systems, or competing priorities. So we'll talk about this a little bit more about people experiencing homelessness. There's an assumption that this isn't a priority. So why should I, bring this forth? Okay, barriers from individuals or, patients, personal beliefs or cultural values that conflict with advanced care planning. A lot of, there's a difference, people who come from more collectivist cultures and individualist cultures. So if we are going at advanced care planning with an individual that comes from more a collective culture where more people need to be involved in the decision-making process, and we are only focusing it on the one person and not including everyone else, then advanced care planning might not seem like something that will be aligned with their values. Or individual. So people that don't have, they just have different beliefs that maybe are a barrier. Communication challenges or strained relationships with providers or family. So in Oregon, we actually have the advanced directive is translated into, I think, like 12 or 15 different languages so you can print out a guide and the advanced directive in all of these different languages. We also, the language used in the advanced directive is a little bit more complex. So I think that's one of the things that they've tried to make more accessible, but communication-wise, and then just the strained relationship with providers or families not knowing how or who can actually, help with this. There's a limited awareness of the advanced care planning process or how to access it. There's a number of people who have distrust in the healthcare system based on systemic oppression, health disparities, and different biases, that they have experienced. And then the complexity and inaccessibility of the documentation and the formats are also barriers. Matthew, you have another question?
You actually are leading right into it with that last one. So social determinants of health would tell me that a person from out of state made a decision. You are referring to the state of Oregon, but let's say somebody from Oregon or from California or Washington, for example, created these documents. As a QMHA, I'm trained to honor a person's choice, but legally, are those documents, if they're from a different state, do they hold the same weight? As a QMHA, I want to honor that choice, but legally, what does another state's documents hold in the state of Oregon for a person who transitioned because of need to be with family or care or whatever it might be?
Thank you for asking that. I normally talk about that, but I did not. So our POST and our advanced directive are state specific. So they are only legal in the state that they originated from. So when you're traveling, or if you move to a different state, you need to get that state advanced directive and POST completed. You can, if you're traveling and you're not able to get the state, you can bring it with you, but it's at the discretion of the healthcare facility. So, most people would not want to leave it up to the discretion of the healthcare facility, whether or not they're going to honor it. They could use it as guidance, but it's not something that they have to follow.
They don't honor it. I had the experience because I had mine done in Idaho, and I moved to North Carolina, and I had to pay the fee again.
Exactly.
Redone. Even though I had just done it in Idaho, it was valid, everything. I had to pay the lawyer to get it redone and everything. So
So and every state, if you can, I've been able to find a advanced directive usually on a government website, their healthcare website. So you can print that off and have it witnessed or notarized. There might be states that I'm pretty sure every state it's either a witness or notary. So you don't have to have a lawyer to complete your advance directive. You can do it on your own without that. Okay. So the other thing, so advance directives, you don't have to appoint anyone to be your decision maker. So you can fill out the advance directive with the different types of interventions that you're comfortable with, and fill out the living will section that has those open-ended questions about who you are, what's important to you, and the hospital is supposed to follow your notarized or witness advance directive, even if you do not have a substitute decision maker. So people, if that is the reason why someone is not turning in their advance directives, because they're waiting to find that perfect person that's going to be able to advocate for them and knows what they want, have them fill it out and turn it in, because you can always add your decision maker at a later point. So it's better to have it, filled out without anyone appointed than to not have it filled out and submitted. Okay. So the other thing is that, let's see.
Sorry, I have
Yeah.
a point. So, can they add their doctor? Like one patient asked me, can he write his doctor's name? I wasn't sure. So,
The doctor's name for
for decision maker, health related
no. So
problems.
yeah, so the decision maker can't be a health care provider, and your healthcare provider, if you don't have any decision makers, then they're the ones who are making the decisions for you. So it is to make sure that you have an outside person that can advocate for you. Otherwise, the default is your healthcare provider that's going to, confer with other providers and even the ethics committee or board of that hospital, whether or not certain things are going to happen. Okay, Matthew, you have another question?
Yeah, somebody wrote in earlier, and maybe if it was discussed, I missed it, but the polls can be put into a registry. I know that, but I've not had any experience retrieving that. But is that registry indefinite? Does it expire? And if you answered that, I apologize, but I think that's something that's confusing.
Yeah, so we have a state registry for the post. We do not have a state registry for our advance directives. So your doctor is the one that submits the pulse to the state registry. And when they receive it, what will happen is they will send you a letter to your mailing address that you put down, and it confirms that they received it. It gives you what your registry number is. It gives you a little pink magnet that you can put on your fridge, and it gives you 3 stickers that actually have it right here. So 3 bright pink stickers that has your registry number and your name on it. So you can put those on your wallet anytime you're outside of your home, so that if something happens and paramedics get called, 911 gets called, they'll know whether or not they should attempt resuscitation or not. Does that answer your question, Matthew?
So
And
yes, except
every 10
for
years.
when
So
the
that's for the
when the paramedics do see that as the registry, but then they don't necessarily have the exact form, is that going to slow down the process of life-saving measures if you are full resuscitation as opposed to DNR, that maybe it wouldn't matter if it slows down?
So the default is resuscitation. So if they, in their initial glance at someone who has had 911 called, if they do not see any pulsed, sticker or anything, if you don't have the magnet or your original on your refrigerator where they ask you to keep it, paramedics have quicker access to the registry these days, so they're actually able to like quickly check to see if this person, is a DNR or not. But the default is they have to attempt CPR. They have to do everything possible to keep you alive until they reach the hospital. And then at that point, the hospital has to do everything possible to keep you alive, to get you stable. So that is default. Does that answer your question?
Yeah, that's helpful. Thank you.
Okay. And we stated before that the pulse needs to be updated every 10 years. So once it gets submitted, if it's more than 10 years old, it might not be followed. Or they'll question it a lot after 10 years. They're not going to question full treatment per se, but they're going to question a do not resuscitate more often. Okay. So we're going to keep going. So just health equity, this is something that's really important to understand, that all individuals should be offered an opportunity to create an advanced care plan. So this means not just requiring them to go to their doctor for assistance, like at an annual wellness visit, but for real health equity, we need to create other opportunities throughout the community to be able to complete the advanced care planning process, or at least initiate and educate around advanced care planning. And this is regardless of an ethnicity, gender, socioeconomic circumstances, as well as access to housing, transportation, healthcare, all of these different things. So it is really, we need a collaborative effort to make this more equitable and accessible to everyone in our different communities. So when we look at health equity and advanced care planning, conversations are shifting from just completing the documents to a deeper understanding of an individual's healthcare goals and values. It's acknowledging and addressing systemic inequities and personal biases. It's identifying and removing obstacles to participating and completing the process, and also seeking cultural awareness and practicing cultural humility. So these are all things that we need to work towards to really provide health equity within advanced care planning. So when we're looking at where we can do better, so when we're looking at LGBTQ plus folks, we need to consider chosen family instead of maybe legal next of kin. We need to look at reduced engagement with healthcare due to a history of discrimination. We also need to look at trans and gender expansive considerations. And I will go through some slides that talk about those specific things that we can educate and help advocate for. When we look at people who are unhoused, experiencing homelessness, we need to look at storing documents. Like, how do we help them store the documents? Like all these paper ones, and paper gets wet, it gets destroyed. So how do we help store? We also want to look at chosen family. Sometimes people are estranged and don't have a lot of natural supports, but maybe chosen family, or even the community partners that they have developed relationships with. Those are the people that might be best. And then also the relationships to medical providers. A lot of those relationships are really strained because we see repeat visits to the hospital, to the emergency room. When we look at BIPOC, cultural considerations, discrimination in healthcare, lack of resources and support in various languages. when we're looking at people living with dementia, we need to look at it as a stage-based progression, and understand that capacity fluctuates. And this also, we can look at a person who's living with Parkinson's, is the same. It's a progressive disease, and cognition can be affected, communication skills can be affected as a disease progresses. People living with serious mental illness, there's a lack of education and utilizing the existing forms that we have in place. We also know that people with serious mental illness and people who are unhoused have a higher mortality rate, and they die sooner than others. And then people living with physical disabilities. So ableism can lead to discrimination around quality of life and advanced care planning conversations. So the way that people talk about whether or not someone would want to be on, have a feeding tube. You know, some people, a lot of people with a physical disability rely on a feeding tube. And so if the way that we talk about these things is going to be ableistic, then we need to understand how to address these things in a better way. So I'm going to go into some of those individual considerations. So why advanced care planning is important for LGBTQ plus folks. So people who identify within this community are more likely to experience health disparities. There's an increased likelihood of encountering the discrimination, you know, homophobia, transphobia, and healthcare and aging services. We had an older adult LGBTQ survey done in Oregon years ago, and it reported that nearly 60% of LGBTQ older adults have experienced discrimination at their healthcare visits. Personal, family, and social acceptance of someone's sexual orientation or gender expression can have major effects on one's mental health and their feeling of personal safety. We also need to help, well, we don't need to help, but people, you know, chosen family, the people who they trust to make decisions on their behalf, need to be identified and legally documented and declared as the ones that can make choices for them. And a lot of the caregivers of LGBTQ plus folks are not related by blood or marriage. And so they have limited legal power unless we're able to make sure that they have that assigned to them. So some of the trans and gender expansive additions that we can have in our advanced directives is things like we can say, you know, I direct that medical staff should respect my identity as a transgender woman or man by only using the pronoun she, her, hers when referring to me, and ensuring that when gendered attire is available, I am dressed in women's clothing. So if someone who is transgender or gender expansive, if they go to the hospital and they are not able to communicate, the hospital is just going to go by what their visual interpretation is. And so oftentimes that's going to be maybe not what gender expression that person has. So we want to make sure that we state this in our advanced directives. Also, you know, I direct my decision maker to speak to hospital staff to ensure that my name, you know, Jennifer, is used when referring to me in accordance to my non-binary gender. Not everyone can change their name legally, so we want to make sure that we state that. I direct medical staff to continue with my regimen of hormone therapy as long as it does not seriously interfere with any other necessary medical care. So these are all considerations that we can help put into, you know, our advanced directives. Okay, does anyone have any questions? I think we're, okay. So why is it important for the unhoused? So I mentioned this before, but it is more likely that a person who is chronically unhoused to have geriatric syndromes. So that means that a person who is maybe, you know, 45 years old, they actually physically would present as someone who is 65 years old. Because of the chronic stress that happens when you're unhoused. So they have a higher mortality rate, increased risk of dying without having their wishes honored. You know, they are focused on day-to-day survival and less likely to initiate or know about advanced care planning. And also it's important because it helps define who might be trusted to make decisions on their behalf. Because just like with LGBTQ plus folks, the people that are closest may not have legal power to make decisions for them. So we want to help that, make that happen. But then also, even if someone might not be appropriate for making healthcare decisions, we could at least document and get information for someone to be an emergency contact. You know, someone that we can get more of someone's social history from. So it's, even if someone might not have legal decision-making, you know, power, we can utilize them to understand more about what this person, what's important to them. So I've added a little bit about the unique fears about end of life for people experiencing homelessness. So a fear of prolonged or painful death, worry that appropriate care will not be offered, you know, so that medical teams will remove life support and that they might withhold pain management. Worry about what will happen to their body after they die. Worry about being another anonymous, unacknowledged, and unmemorialized death. You know, when we have overdose deaths, and I have connections within harm reduction organizations and different programs. And it is not only distressing for the other participants of those programs when someone dies of an overdose death, but the staff, because oftentimes they're just gone. We don't know like who their family is. We don't know, you know, what happened to their body. We don't know how to participate in any after death. So that is a real fear. Worry about dying alone and fear of dying in the hospital or in a skilled nursing facility, because that is becoming our default end of life place for people who do not have a place to die. More and more our skilled nursing facilities are taking this default role of end of life. Okay, so appointing decision makers. I'm going to talk a little bit about, it's really important for people who are aging alone for any reason. And we are seeing more and more solo agers. So people who don't have any, they're like the last of their family, you know, all of their people have died. And they don't have a lot of community connections. You know, COVID took away a lot of our older adults' ability to maintain connections, and we're working to re-engage and reinitiate connections with a lot of people. But there's a lot of folks that they're like, I don't have anyone, you know, and one of the things that is happening now in Oregon, and this is brand new, and I don't have a lot of information about it, but I do know that the Oregon Public Guardians just got approved by the legislature for less restrictive decision-making abilities. So that means that they may be able to train volunteers to be healthcare decision makers for people. So this is a possibility that they will get trained to be able, just like being a public guardian, you know, they get the training and make sure that they are taking the lead of the person, that there would be volunteers that are also trained to take the lead to be someone's healthcare decision maker. So you don't need to have no legal decision-making capacity. So this would be someone that just doesn't have anyone. They could still reach out to the public guardians and ask if they could get a volunteer healthcare decision maker, and that would be their only role. So that's kind of exciting that other states have nonprofit organizations that will train people to do this role as well. We just don't have many that I know of in Oregon that will do this. So this is something that maybe someone here in this training might get inspired to look at. And then appointing decision makers is really important for people that don't foresee support from their family, or people who are estranged from their legal next of kin, and they want to appoint chosen family to make those decisions. So I'd like to add this next of kin and like the hierarchy of who is our default decision makers. If we do not assign anyone, it is our legal next of kin who is going to be attempted to get in contact with to make those decisions for us. So a lot of times when I'm working with people and I say, you know, do you have any family? And they're like, well, I have a sister, but I haven't talked to her in like 3 years. Or, you know, I have a kid, but I'm estranged from my kid. And I ask them, if you're unable to communicate, do you trust that that family member is going to know what you want and is going to honor your wishes? And they're like, no, you know. So if your legal next of kin is someone you do not want making your decisions, you really need to appoint a substitute decision maker to make sure that your wishes are going to be carried out. Okay, so people living with dementia, this is one of the most common reasons people lose their ability to guide their own care, is dementia in some form. So I like to talk to people at some point within advanced care planning that it's really important to think about what if your memory or your cognition, or if you get dementia. You know, so let's think about like what you would want. And so it's important to kind of just include this in conversations at some point. I don't start off with it, but it's a good thing to, you know, kind of bring in at some point. So this is where the decision-making continuum comes into play, because even if someone has a substitute decision maker, we need to make sure that we're providing supportive decision making as much as possible. So capacity is not a static state, typically. So there are times in a person's day, a time, you know, in their life, or periods of time where there's more clarity, you know, and so during that time of clarity, we need to work towards including them in the decision-making process. And that's where supportive decision-making comes in. So even like a guardian who has the right to just make decisions for someone, they need to work towards supportive decision-making and take the lead of the person. So there's this like, it's kind of an ethical tension between the do no harm, what's best for the person versus a person's autonomy. So there's this balance that we have to work towards when we are making decisions for people. We want to make sure it's supportive and not substitute as much as possible. Okay, so dementia addendums, I want to talk about this a bit, is that we do not have dementia addendum that can stand on its own in Oregon. So we have the advanced directive. We do not have a dementia directive that is its own separate thing that can just be submitted on its own. Your advanced directive has that little question that says, are there any documents that you want to add to your advanced directive? This is the only way for your dementia addendum or directive to be acknowledged legally, is if it is put in your advanced directive. And so our advanced directive, there is one on the OHA website that is acknowledged, and that is just called the Dementia Directive. Anyone and anywhere in the country can use it. We also, there are a few that were created in Washington by End of Life Choices Washington that I really like. They all talk about, you know, different instructions based on the stage that you're in. It also talks about feeding and drinking and hydration. So, you know, saying that if I get to a certain point, I do not want people to like give me a feeding tube. I just want to have a natural death at that point. If I'm, there's other additional directives in some of the Washington ones that creates the conversation to be had around these different subjects. So it can create the conversation around like how to deal with combative, assaultive, or aggressive behaviors. Are you open to, you know, being in a facility for a period of time to see if they can address or tend to the needs that are needed? In dementia care, you know, we say that there are no bad behaviors. They are just communications that some need is not being met. So while we're figuring out what those needs are that are not being met, we might need to be in a higher level of care. Is that okay? So it's good to have those conversations about financing care, preferences regarding future intimate relationships. It is, you know, it happens quite often that someone who goes to a memory care or a higher level of care might form intimate relationships with other people there. And the person who is remaining, you know, at their home, that partner might also develop relationships. So it's kind of, you know, let's have those conversations ahead of time to reduce any amount of guilt or shame that we're feeling because of this is, you know, taking place. And then also having those conversations ahead of time about participating in experimental drug trials. It might not happen, you know, it might not be offered, but it might be. So the point is that these advanced care planning documents are not just to write down your preferences for healthcare providers. It is also a means, a doorway into having conversations with our caregivers and our loved ones around topics that maybe aren't going to come up naturally and on their own to help us, you know, a lot. And Matthew stated something that I hope everyone here understands. especially in older adults, UTIs, so urinary tract infections, have a really different effect. So in older adults, UTIs can lead to hallucinations, can lead to delirium, can lead to aggressive, assaultive, combative behaviors. And as soon as the UTI is resolved, then all those things go away. So it's pretty interesting, and hopefully every medical provider and caregiver knows that if you have someone who is kind of all of a sudden acting differently, UTI is the first thing that should be kind of looked at. Okay, so person-centered support with dementia. So we know that capacity and cognition fluctuates. Recognition of different articulations of wishes through gestures or nonverbal actions or emotions. Allowing ample time over several meetings. What time of day is best for the person. And then also repeating information. So we want to be very aware of how a person expresses themselves, even if they are at more advanced stages of dementia. We want to recognize, their different communication cues and include that when we are making decisions for that person. We also want to look at trans and gender expansive considerations for people living with dementia. So this is something that not everyone, is going to utilize, but it's really great for all of us to understand that these are the things that for an older adult who is trans or gender expansive, and they also are living with dementia. These are some of the questions that we can ask around advanced care planning. So how do I understand my gender identity? Do I understand my gender in a more fluid way? Do I want my caregivers to respect my gender fluidity in the event that I'm no longer able to advocate, do you want to continue receiving hormone replacement therapy? Who will you designate as your power of attorney? If it doesn't have to be someone from your family or origin. So this is like just a list of questions. If you're working with someone who lives with dementia and is also gender expansive or trans, these are good things to kind of hit on all the possible things. There are the possibility that someone with dementia one day might have a gender expression that's different than what they first arrived at the facility with. And so to talk about the fluidity of cognition and gender. So we can add, I direct that care staff should respect my identity as whoever. If my gender expression fluctuates, please use the pronouns I am using when referring to me, and ensure that when gender attire is available, I'm dressed in affirming clothing. So there's a lot of fear of becoming more vulnerable and unable to protest against misgendering and other microaggressions for older adults who are trans and live with dementia. So this takes a lot of awareness from the care staff to really kind of like follow a person's lead and see how are they referring to themselves, right now. And that's how I'm going to refer to them as ahead of time. Okay, Matthew.
So generally, I don't use stereotypes as absolutes, but for this question, if I know that somebody's Muslim or that they are Jewish or Seventh-day Adventist, that generally tells me no pork. If I know that they are Jehovah's Witness, generally no blood. But do those things need to be documented in an advance directive or some type of thing to ensure that their dietary and their concerns for Jehovah's Witnesses, stereotypically no blood, are honored? Can you speak to the archetypal
Absolute-
truths?
Yeah, absolutely. Those need to be added into advance directive in hopes that if they don't have an advocate, that the providers will read that and understand that that is part of their preferences and their wishes. And then if you're living in a long-term care setting, you should have a care plan. Every person has their own care plan, and we need to make sure that those directives are included in that care plan in the long-term care settings. And to ahead of time, ask the questions, you know, to the long-term care to see if they're going to honor someone's wishes. You know, if I have a dementia addendum to my, you know, to my directive, my advance directive. Here's my advance directive with my dementia addendum. And it states that if I get to the point where I turn my face away from food being offered to me, if I, you know, am combative when someone is trying to give me food or drink, I give you permission to, you know, let me not receive those things. And some care facilities are going to be like, no, that's liability, you know. Other people are going to be like, okay, you have it documented in your advance directive. We feel like this is enough to protect us from being seen as like negligent. So there have been a number of, you know, studies or cases where this has happened, where a person had it stated and then the family was upset, and then the facility was like, but this was stated, you know, or the family, the other way, the family's like, they said they don't want this, and the facility's like, we're uncomfortable not, you know, giving them a feeding tube. So it's good to ask these questions when you first get into a facility, or, you know, looking at what facility you actually want to be in. Even asking, what are their thoughts on death with dignity? Would I be able to do death with dignity if I moved into this retirement community? Okay, so I know you spoke about capacity. We also speak to capacity and how this plays into the documentation. I know competency is legal term. So capacity is decision-making capacity. So capacity is determined by a clinician, and competency is determined by a court of law. So if you have your capacity, you know, stated by a clinician, you do not have decision-making capacity, then that will affect your ability to sign a advance directive. So your substitute decision maker, you know, is then steps in to make decisions for you. So you want to make sure that you appoint a decision maker that you want before your decision-making capacity is declared as not there. Does that answer, Louisa?
So with someone who wants to contest it, though.
You have to do that through the court of law.
Okay, so if a clinician determines that someone lacks capacity, so then the decision goes to the identified person in the advanced care plan, correct?
Yeah. Yep.
All right. But then if that person wants to contest it, then it has to go before a judge?
So, I mean, yeah, to contesting a legal, document, you would have to go take it to court.
Okay, I know that's all in the hospital setting, that was always pretty unclear. You know, in order for the, say, a guardianship document to be enabled, a person had to lack, I don't know if it was both or just one. So, okay, I'll keep working on that. Thank you.
Okay, and maybe I'm not answering it correctly. I'm not sure. So yeah.
I'll think
Think
about it
about-
further.
Okay. 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 So some of the questions that are good to go through before filling out any forms with people. And there is a really great serious illness conversation guide that was created for physicians, but different groups have adapted it for more community-based providers and support people. So this is something that I'm going to be working on, to kind of adapt it for non-medical professionals. But the gist of what's in there is, finding out what is someone's understanding of advance directives and pulse. Do they have any fears or concerns around, doing advanced care planning? What supports do they have? Who is their legal next of kin? What conversations have happened so far? Have they ever talked to anyone in their family or their, friends? Have they ever talked to their healthcare provider? Have they talked to their, kids or to their parents? Do they have an understanding of their medical condition? And do they have an understanding of what it could look like if it progressed? What are they hoping for? And what does living well mean to them? So we also have what are their past hospital and serious illness experiences? What did they learn from it? Because a lot of our fears are rooted in past experiences, either us observing a family member or our own personal experience. So what did we learn from it? Some of them are positive and some of them are negative. And then also, what are their cultural or spiritual beliefs? Either that relate to quality of life or that relate to how they make decisions. Like we talked about before, some of us come from cultures that are more collectivistic than individual. So to better understand that will be beneficial. And then I like to include advanced care planning for after death. Because when you look at, we talked about the concerns of unhoused, folks around end of life. So if we know these things, then we can convey this to people so that they might have a little less anxiety about what's going to happen to their body. So we have two things that I'll go over. The first one is we have a form that's called the appointment of a person to make decisions concerning disposition of remains. The longest title to any form that I've seen in Oregon. And then also I'm going to talk about the indigent disposition program. So this first form is appointing an after-death decision maker for disposition. So this is how we can ensure that chosen family and support people have the legal right to do our after-death care plans. Matthew, do you have a question?
Yeah, a durable power of attorney. We've talked about the different power of attorneys, but is it my understanding and your understanding that a durable power of attorney is both power of attorney and appointing of a healthcare representative? What is the value of a durable power of attorney?
So a durable power of attorney for finances is for financial things. A power of attorney for healthcare allows you to name a person to make healthcare decisions for you when you're not able to. So financial power of attorney, you can let someone have the ability to make financial decisions for you before you don't have legal decision-making capacity. Or you can state only once a doctor has declared that you don't have decision-making capacity will this kick in. So financial power of attorney, you have those two different, so either right now it'll kick in, or it only kicks in if I'm deemed enabled to make decisions. Healthcare power of attorney, as far as I know, is only if you are unable to communicate your wishes, or if you don't have legal capacity. And so it is not often that you combine the two. However, I was told recently by an attorney that they have created a combo finance and healthcare power of attorney. It
That
doesn't
was
seem
what
like
I was thinking too, and that's kind
it
of what my
doesn't
question
seem like
was.
the best idea to do that. You know, but yeah. So Shoshana says, this is a common stuck place in hospital settings, families stating that they have power of attorney, and when they present the documents, it covers legal, financial, and not healthcare. So very true. So power of attorney for finances is not the same as healthcare. So we need to make sure that people understand that. Also, so the Oregon Mortuary and Cemetery Board created this document. So this is something that was created by the governing body of all funeral homes. And this document allows you to appoint a decision maker and one alternative in the event that they're unable to contact the first one to make decisions for you after the time of death. So this will not let someone purchase funeral arrangements ahead of time. To do ahead of time, you have to have financial power of attorney because it is a financial agreement. But after someone has died and you have this form filled out and it only needs to be witnessed, it doesn't even have to be notarized. You can have it notarized if you want, but you can just have two people witness this form and it'll be enough. And this form will trump a person's power of financial attorney. And it's good to know this because if someone is estranged from their family, let's say there's a trans individual whose family does not agree with their gender expression. If that family has power of attorney, it doesn't matter because if their chosen person has this form of being a decision maker for disposition, it overrides a power of attorney. So you need to know this because funeral homes sometimes will misspeak. So this shows that sometimes you have to advocate and tell a body, like, no, actually, this is the Oregon Mortuary and Cemetery Board made this document, and they have stated that this overpowers a power of attorney. So it's really important to understand that. Does anyone have any questions about this document? Okay, I'll look at questions in just a moment. Okay, so the next question is what happens to a person's body when nothing is in place? So let's say you have a client and they don't have any family that is able or willing to step forward and help with any funeral stuff. Or we have someone that we have no idea who their next of kin is and we can't figure out. You know, so in Oregon, every county typically has a 3-month rotation of on-call funeral homes that are engaged by law enforcement. So if someone, dies, then law enforcement will call whoever the funeral home is that's on call. And if the deceased person does not have any family or family cannot be found, or they refuse to take financial responsibility for the funeral arrangements. then there is a program where that funeral home can ask the state to offset some of the costs to do the disposition of the body. So typically, that means that the person is going to be cremated. So the funeral home has an obligation to first reach out to any of the research facilities and see if anyone needs a body donation. It typically doesn't, a lot of people don't need body donations. And so they will first see if anyone is needing body donations. And then the second thing is they're going to do cremation because it's the most inexpensive thing for the funeral home for disposition. So they will do the cremation, and then actually, let me go back. And then what they do is once they apply for the indigent disposition program, then they become the legal owner of those remains. So it's up to their discretion on whether or not they're going to hand off those remains to individuals that come to them and say, hey, you know, we were really close to this individual and we were hoping to take the ashes and be able to like scatter them. It is up to the funeral home to say yes or no. So they have the obligation to keep the ashes for 20 days and do their due diligence to try to find someone who will financially pay for the process. But after 20 days, then they can then inter those ashes. And typically funeral homes have a communal place where they inter ashes. So people do it in a respectful manner. They don't go to the dump, which is what I've heard, you know, that, I mean, there's a lot of like really kind of nasty urban myths that go around what happens to people that, you know, don't have money for their, you know, disposition, their funeral stuff. So they are respected, and some, it's just a matter of storage. So some funeral homes will keep the remains for a long time. Some will hand them off. Some will say, if you can pay me, then we will give them to you. And other people just want someone to sign a form that says, I received these remains. So you just have to talk to the funeral home and advocate for that. Okay, so just a few more slides and we'll have time for conversation. So these are some of the things that other people are doing across the country and what I would love to see us doing and creating here in Oregon. So the first thing is we really need to bring advanced care planning beyond the clinic, beyond the healthcare setting. So we need to implement advanced care planning activities in non-medical settings. So doing things in libraries, with faith communities, at senior centers. We need to broaden the reach and reduce the stigma around advanced care planning. We also can expand advanced care planning training across the sectors. So training case managers and peer support specialists and community health workers and, you know, different people across social service providers on how to have these conversations with the participants and our clients that we see on a regular basis. We are the ones that have a relationship and have time to develop a relationship and trust with people. So it is more likely that a person is going to open up to us about what is meaningful to them, and for us to figure out how to help advocate and utilize advanced care planning to benefit the people that we work with. And then also integrating family and proxy decision makers. Proxy is just another word for substitute decision makers. Encourage inclusive conversations that involve family members and our designated decision makers, so that there's a shared understanding and maybe they're a part of the decision-making process. There's so many times where, you know, you ask, do you have an advance directive? And they're like, yes. And they're like, have you talked to your decision maker about what you want? And they're like, no, you know? So in Oregon, we're one of the only states that we have to, our decision makers have to sign and accept the role to do it. So we know at least there's been one point of contact with a decision maker because they have to accept it. But beyond that, who knows if there's ever a conversation around it. So we want to encourage and provide those spaces to have those kind of facilitated conversations to make sure that everyone understands what's happening, what's the plan, are there any doubts or fears or questions? And we want to increase community-based end-of-life support. So this is really a thing that I promote, being an end-of-life doula myself and coming from a more grassroots community-based background. It is very helpful to promote and to utilize and to normalize community-based end-of-life supports, because it is more likely and more accessible to get training and to include these end-of-life doulas into our care teams, especially when they have lived experience, you know, in different areas of being unhoused. So if we can provide, you know, training to our community health workers around death doulas and end-of-life care, which there is a training, Peaceful Presence developed it specifically for community health workers. So that is available. And then also to understand that end of life is not a medical experience. We have it kind of flipped. So end of life and death is mainly an individual social experience that has a medical component. But our culture in the last 100 years has flipped it and made end of life and death a institutionalized medical experience when it is not. And that's one of the reasons why we have so much stigma around it, is because it doesn't actually fit with our personal experience of end of life. So when we have our personal experience not fitting with the narrative being told to us, that's typically when stigma occurs and is maintained. Okay, so we need to strengthen partnerships between healthcare and community-based organizations so that we have this collaborative effort between, you know, different things to make it culturally appropriate. So different organizations. So we have like BASE in Southern Oregon, which is, I cannot think what the acronym stands for, but it is our like a Black advocacy and community resource organization. So if we can find different community-based organizations that are culturally specific and work to have advanced care planning happening by and within those organizations, that is going to be really great. So that's going to empower diverse community organizations to be able to serve the communities that they are within. And there's a lot of trust. So people who have had, you know, systemic oppression and discrimination, if the person that is doing the advanced care planning is a part of their culture, then it is more likely that it is going to be utilized and it's going to be, you know, done. And then also developing equitable and accessible ACP tools. So creating resources that are user-friendly, culturally responsive, and available in multiple formats and languages. One of the things I missed was for unhoused folks, actually having community-based organizations house some of these documents. And then creating laminated wallet cards that say, you know, I have an advance directive, this is my emergency contact, and having those organizations helping submit the records to different, like to your hospital. Because it's important to submit your advance directive to wherever an ambulance would take you. So what ambulance, where is it going to go? That's where you need to submit your advance directive, a copy of it. If you were life flighted somewhere, is that different hospital system? That hospital system needs to have your advance directive, because most of us here probably work within EHR, electric health record systems. And we know that there's not this magical universal health records that everyone can access whenever they want. It doesn't exist. So we are very fragmented amongst each other. So it is really good that different organizations can house that document, so that if we know that a client, you know, had an event and ended up going to the hospital, we could actually be like, hey, we have their advance directive. You know, do you have their advance directive? Here's a copy of it. So it's good to think, can we actually add that to our EHR records for our clients? Let's see. And then these are some ideas of how we could do conversations. So during program enrollment, during any sort of regular or annual appointments that we have, you know, if we have housing transition plans, care coordination plans that we're working, like collaborative working with a client, and then any post-hospital follow-up would be really great for that. So this is the last thing. It's really important to remember that it's a process. It's not an event. It's not a single conversation. And so I have resources. I'll actually add more before we send the slides out. So different resources in general, some dementia resources, LGBTQ plus resources around advanced care planning, and our Oregon specific forms, and the sample form that you can print out for the post as well. Okay, Janine, you can end.
Great, Angela. Thank you for such an excellent training. I will send out Angela's slides. I will also include our YouTube link, which is the recording of the training. We are offering 2 NASW CEUs, so in that email, we'll have the evaluation for you to complete the evaluation and send back to me, and I'll send out the NASW certificate. And then Portland State University will also, or hopefully will send out an email asking for feedback and any comments that you have, and any ideas that you would like for our trainings coming up in next year. And our next training is Mental Health Advanced Directives with Dr. Avila, and I did include that registration link in the chat, and I'll also send out that with that follow-up email. And then in October, we have Managing Challenging Behaviors in Residential Care Settings. So thank you, everyone. And thanks so much, Angela. Great training.
Thank you.